A little bit about acute pancreatitis. Make sure that you read some of the slide comments too. I don't have comments on every slide, but there's a couple, so pay attention to those, okay? I want to go back and look first at this slide. This is a CT scan image of acute pancreatitis, and actually now you should be able to at least walk through a transverse section of a CT scan and sort of know what you're looking at. As we move through this presentation on acute pancreatitis, look carefully at the ultrasounds that I show you and the CAT scans, and just recognize how much you guys have learned over this past year. On this scan here, we can see the gallbladder. Here's the liver. We're seeing the left kidney here. This is the adrenal gland. Here's the aorta. Of course, this is the crura of the diaphragm. And then what we see here is what's left of a pancreas. And all this fuzzy stuff that you see around it here is edema. This is fluid and inflammatory contents all around the pancreas. This the pancreas is right here, at least what's left of it. And here, of course, is vena cava. This is probably duodenum, although I'm not 100% sure looking at this just one slice right here. And this is probably a little bit of small bowel that has oral contrast in it. But just what you've had already, you can look at this and tell me that this is not a normal looking pancreas by any means. So I have included several readings, and they are included in part of this PowerPoint. So make sure that you download these. I'm not going to ask you to read them if you don't want to, but it really does make your learning a lot better, because a lot of times I will take one of these readings and simply outline it. And I think I've probably done that with the first two here. This is a chapter from the Scientific American Surgery series. I've included that here. We'll get to that, and you can download it on the next page. So there are actually supposed to be three documents here that you can download. There is a famous grading system for acute pancreatitis. It's called Ranson's criteria. Here's the original paper. I went back and asked the library to find that. And here's the acute and chronic pancreatitis chapter that I referred to. And then something called the step-up approach for evaluating and treating open necrosectomy for necrotizing pancreatitis. So take this out of PowerPoint view mode and down click on each of these, and you can download these. If it doesn't work for a Mac user, I'll send these along as attachments when they post these PowerPoints for you. So there's a lot of learning objectives. We'll go through these, and I'll see how many I can answer for you as we go through them. I also put a doc file. It's on the next to the last slide of this presentation that has a printed version of our learning objectives. So first and foremost, describe the step-up approach to the patient with acute pancreatitis. If you go back and read this article that I mentioned to you, you should have no problem in answering that question. So define acute pancreatitis and how it differs from chronic pancreatitis. Here we have some images of somebody who has calcifications in the pancreas. That's pathognomonic for somebody who has chronic unrelenting pancreatitis. And then they have what's called a pseudocyst here. This is a person who has acute pancreatitis. Here, of course, is the pancreas. You recognize this in the retroperitoneum. Here's the aorta, the cava, the portal vein. Here's air in the duodenum right there. Here is pancreas, but around it is this edematous, irritated, inflammatory fluid. This is acute pancreatitis. So why is acute pancreatitis now the most common GI discharge in the U.S.? It's because of gallstones. There's a disease called gallstone-induced pancreatitis. We just call it gallstone pancreatitis. You'll see how that diagnosis is made and how we treat it. What are the four main goals in the treatment of acute pancreatitis? We'll cover those. Describe the preferred grading system for acute pancreatitis and why we use these grading systems. And as we go along, talk about which antibiotics are recommended in the treatment of acute pancreatitis. Over here is a patient who has chronic pancreatitis. They have a big giant pseudocyst in the head of the pancreas. And down here is how we can treat chronic pancreatitis. This is called a Pusteau procedure, and we'll get to that later. So what are the most common causes of acute pancreatitis? Number one is probably gallstones. What is a pancreatic pseudocyst? Right here. What causes it? It is chronic pancreatitis. The body of the pancreas itself begins to auto-digest, and it forms a cyst. And then before we touch it, before we even begin to think about operating and draining it, we have to let it get this nice wall that's developed around it. We let the cyst mature. So we give it at least 6 weeks for this wall to mature before we can stick any needles through it or do any surgery on it and drain it. So when should a pseudocyst be drained? At a minimum after 6 weeks, as long as it's not infected and the wall has matured. How should it be drained? We can drain it by cutting you open, or we can do it endoscopically. What do pancreatic calcifications indicate? They indicate chronic pancreatitis. And here's some tiny calcifications up here that used to be part of the pancreas. What is saponification and how is it relevant to pancreatic disease? You can click on this link here. And in fact, we'll do it. And it's going to take us to what saponification is. And if you remember from your organic chemistry, we'll learn a little bit about why saponification is going to come up and bite us now when we're in medical school, when we thought we could forget all of that stuff. So right here is the answer for a saponification. Fat necrosis within the pancreas is due to action of lipase. That's an enzyme created by the pancreas. Fat necrosis is due to the action of lipase on triglycerides, which subsequently release fatty acids from the fat cells. These fatty acids combine with calcium and form insoluble salts, and this process is known as saponification. There you go. Organic chemistry did come back to haunt you. What is the Pusteau procedure? It's this over here. People with chronic unrelenting pancreatitis have what we call chain of Lake's dilatation in their main pancreatic duct, or they get chronic calcifications within their pancreatic duct secondary to saponification. So we just split the pancreatic duct open, and then we sew a piece of intestine over it so that the pancreas now can drain into the piece of intestine, because what happens, the calcifications within the pancreatic duct keep the exocrine functions of the pancreas from draining. And remember, there's endocrine functions of the pancreas. What does the pancreas make? Well, we know about insulin, glucagon, bicarb is a exocrine function. Amylase and lipase are exocrine functions. Endocrine function will include the hormones, of course, that the pancreas makes, most notable of which is insulin. And then what is a pancreatic phlegmon? A phlegmon is just a great big giant area of inflammatory process within the pancreas itself. What is gallstone pancreatitis? We'll talk about that a little bit later, and I'll show you how that forms. So how can parathyroid disease cause pancreatitis, and how is that related to hypercalcemia? Well, our parathyroid glands release parathyroid hormone, and that helps us regulate the serum concentration of calcium within our bloodstream. So if someone has parathyroid disease, let's say they have a parathyroid adenoma, which is a small benign tumor of the parathyroid gland, and it makes too much parathyroid hormone, all of a sudden we have hypercalcemia. And then hypercalcemia, of course, can be saponified out when the pancreas has this autolytic function of its enzymes auto-digesting it. So as it begins to auto-digest, and if we got excess calcium around, it'll saponify. What is the duct of Wirsung? Well, here's a picture of it. The duct of Wirsung is usually the main pancreatic duct, and the duct of Santorini is usually the minor pancreatic duct. But occasionally, they form into separate openings. So here's a case of pancreatic divisum, where the minor duct, the Santorini, actually turned out to be the major duct. And then the minor duct of Wirsung which should be the major duct, turned out to be the minor duct. So this is called pancreatic divisum. Here is a normal pancreas and how it normally would look. So what is the embryology of pancreatic divisum? I think you can see how when the ventral and dorsal buds of the pancreas begin to swing around the duodenum and form and convalesce, then they will form either a normal pancreas with the papilla of Vater with the opening conjoined with the bile duct and the duct of Wirsung, or it'll form into something funky like this, where the major duct all of a sudden is derived from the minor duct. And then, of course, what is the embryology of annular pancreas? That's where the ventral bud and the dorsal bud, join together, but it doesn't go away and dissolve itself, and you end up with pancreas completely surrounding the duodenum, pinching it off. And we'll see a picture of that later. There are two anti-metabolic medications that can cause acute pancreatitis. What are they? What's Cullen's sign and Gray-Turner's sign? If those sound familiar, it's because we talked about them as part of the retroperitoneal hemorrhage when we looked at the anatomy of the muscles of the abdominal wall. So what do Cullen's and Gray-Turner's sign indicate? Usually that there's retroperitoneal hemorrhage, usually hemorrhagic pancreatitis. And then explain anatomically how they occur. What layers of muscles does the blood actually lie in between? What's an ileus? How is it diagnosed on a clinical and physical exam? And how is it diagnosed on abdominal films? An ileus is nothing more than your intestines are sick. That means they're not percolating, they're not peristalsing. Something in the body is making your intestines not work, and they just lie there. This is what happens when you get the stomach flu or you go to a restaurant and you eat some bad food. Your intestines just lay there. They don't want to digest anything that's not healthy. And so we'll see some examples of this and what it looks like on x-ray. But an ileus is just lack of peristalsis of any of the fluids of your small intestine or of your colon. And how is it diagnosed clinically? Usually your patient will come in with a big distended abdomen, not necessarily tender, but full of air. The bowel sounds will be kind of quiet because there is no percolation, there's no peristalsis. And then how do we diagnose it on abdominal films? It looks a lot of times just like a small bowel obstruction with big dilated loops of small intestine, but usually these are full of air. We'll see what that looks like coming up. What's the colon cutoff sign of pancreatitis and what causes it? We got an example of that too. What is the most accurate and sensitive pancreatic enzyme in the diagnosis of acute pancreatitis? It's lipase, serum lipase. And if you want to be really picky, the best way to diagnose acute pancreatitis is to get a urinary lipase. We never do it, but it is the best way to assess for it. So over here on the right, we have what's called a dynamic CT of the pancreas. A dynamic CT is used when we're worried about somebody who has acute pancreatitis, and we want to see how much of the pancreas is perfused, how much of it is getting blood flow. How do we find out? We give you a nice slug of intravenous contrast, and we time it so that as the contrast goes and percolates through the pancreas, we take our sections right then, and any part of the pancreas that doesn't light up is considered to be dead or necrotic pancreas. Now on this scan here, what we actually see is a dynamic CT scan where the pancreas is lit up. It's kind of white, just like the kidneys here, and the cortex of the kidneys is sort of white from the IV contrast. But the arrow is pointing out a tumor in this. But nevertheless, this is an image of dynamic CT of the pancreas. So when is it used? If you got a patient who's got pancreatitis and you need to find out how much of the pancreas is dead or necrotic, you would order a dynamic CT scan of the pancreas. And I'm always telling you, don't order abdominal CTs. Always get your pelvis with it. So what is the CT severity index grading system? We'll look at that too. Ranson's criteria. Now, when I was a third-year medical student, they made us memorize Ranson's criteria. The sad thing is there are so many other criteria we use today that will predict the mortality of our patients a little bit better than Ranson's criteria. But this is all we had for several years. If you go back and look at the original paper that I gave you and download it, you'll see that paper was written back in the 70s. But as a third-year medical student and as a surgical resident, we had to memorize these criteria. I don't think it's necessary for you to memorize them, but you should at least be able to recognize which ones are criteria by looking at a multiple choice question. You should know which criteria do not belong. I don't think it's fair for me to ask you to just spit them out from rote memory when you can look these up on your iPhone or your iPad. So what's the BISAP severity index score for acute pancreatitis? And why is it preferred? Well, it's preferred, and you'll see, is because it's easy to use. Compared to Ranson's criteria, which makes you look at the patient at 24 hours and again at 48 hours to come up with numbers. And here's some slides if you want to go look and see what they are right now. And then there's also something called the Atlanta classification of acute pancreatitis. So check this out. We've got a CT severity index, we got Ranson's index, we got bedside index, we got Atlanta classification, and we'll look at all of these, but I don't expect you to memorize them. Please do not memorize them. The only ones I would ask you to really know would be to recognize on a multiple choice question the parameters that make up the BISAP and the parameters that make up Ranson's, because it's just classic that you have to know this. I'm sorry. What are the inflammatory mediators of acute pancreatitis? And of the most common mediators that we have, which one is the most useful one to define severe pancreatitis? So over here, what is an endoscopic retrograde cholangiopancreatogram, an ERCP? What is it and what is it used for? Well, let's go back and look at this. If someone comes in with gallstone-induced pancreatitis, known as gallstone pancreatitis, here's what happens. The gallbladder is full of stones. Great big giant gallstones do not cause gallstone pancreatitis. It's the little ones. These little tiny stones get spit out into the cystic duct, go down the common bile duct, and they get stuck right here. So the pancreatic duct, usually the duct of Wirsong, the main pancreatic duct cannot drain. It cannot drain its bicarb or its amylase and lipase. And the bile duct cannot drain bile. Bile helps digest fats, and so does amylase and lipase. So a stone gets stuck here, and what happens is everything backs up. The bile backs up, the patient becomes jaundiced because the bile cannot leave the liver, and then the pancreas gets pissed off, and they get acute pancreatitis because the pancreas cannot drain. So an ERCP allows us to put a scope down into the patient's mouth, into the duodenum, and it's a side viewing scope. It's not the camera's not at the end of it. The camera's on the side of the scope, and we can instrument the bile duct and the pancreatic duct, and we can pop and pull these stones out by using a little balloon on the end of it. So this is what it looks like from using a fluoroscope. So here's the scope going down into the duodenum. In this patient, they've already got a little tiny wire catheter up there, and it's all the way up into the common bile duct, and this common bile duct is really big. Do you remember the number I told you to memorize on how big the common bile duct should be? It should be less than 8 millimeters. 8 millimeters is the upper limit of a bile duct, okay? So what is an ERCP? Now you know. What is TPN, total parenteral nutrition? Basically, that's how we feed you if you can't eat orally. What is enteral nutrition? Well, a Big Mac is enteral nutrition, but in the hospital, we put feeding tubes in you down into your stomach and past your duodenum down into the jejunum so we can feed you directly into the small intestine. Why would we give somebody intravenous nutrition over enteral nutrition? Well, if you cannot eat, or your intestines are sick, or you've had all of your intestines removed, we may not want to feed you enterally. We might have to feed you intravenously. And then we do know that one of the causes of pancreatitis is hyperlipidemia. So if a patient comes in and his lipids is in the thousands, and this patient has acute pancreatitis, we probably don't want to put lipids in their IV nutrition because they already have lipids floating around in their blood, which was excessive that caused the pancreatitis. What is abdominal compartment syndrome? Well, this one you know about. You know what compartment syndrome is. Well, what is abdominal compartment syndrome? Well, it's when we take somebody to the operating room, split them open, and then we can't close the abdomen back because they're so distended, they're so edematous, the intestines are so swollen. So how do we diagnose it? We put a Foley catheter in your bladder and we measure the pressure on your bladder when it's full. And if that pressure is sky high, we know that you have abdominal compartment syndrome. How is it treated? If you're in the intensive care unit and I've just operated on you and I've closed your abdomen and your abdomen is so freaking tight that you can't breathe, then you're going to be put on a ventilator. So I take you back to the operating room. I open your belly up. I split you open again, but this time I leave you open and get rid of all that pressure that was on your abdomen. So in that case, we can actually sew a zipper in you if we have to plan on going back in and doing debridements of your pancreas. Or we can sew in a temporary patch called a Whitman patch. You'll see pictures of that in a sec. So how does acute pancreatitis cause a left-sided pleural effusion? Back in cardiopulmonary, we talked about how pancreatitis can cause a sympathetic effusion. The left lung and the left thorax gets irritated from all the inflammatory mediators as a result of the acute pancreatitis, and then fluid is exuded around the inflamed lung tissue, and lo and behold, you end up with a left-sided pleural effusion as a result of acute pancreatitis. So how does acute pancreatitis present? Well, it's usually very quick in onset, depending on what the cause is. The pain is usually epigastric. It can radiate to the back or the left flank. They'll tell you it's the worst pain they've ever had. Sometimes they have a lot of vomiting from the ileus because their intestines are not percolating. All this inflammatory fluid that you see in this CT scan over here pisses off the intestine, and the intestine doesn't want to percolate. So they just lay there, and subsequently you end up vomiting because all the fluid that your intestine makes normally can't go anywhere. Sometimes there's no pain, only shock. They come into the emergency room, they're hypotensive, they're sweating, and guess what happens? Hypotension, low blood pressure is not good. It causes the blood flow to the pancreas to be even less than what it is on a good day, and that hypoperfusion can worsen the pancreatitis. So imagine doing a dynamic CT scan on this patient, which is what we've got here, and what we're looking at with these arrows is all this edematous dead pancreas here. This is alive, this is alive. Here, of course, is probably the celiac trunk taking a left turn going over towards the spleen here. This is probably the beginning of the splenic artery. So aorta, we have vena cava, we have portal vein, we have dead pancreas. So if this guy comes in hypotensive, his pancreas isn't getting perfused on a good day from this acute pancreatitis. And then if all this swelling has given him compartment syndrome, he's not going to get any blood to this organ, and it's going to end up dying anyways, and then he'll end up dying. So, of course, they come in short of breath because they have that associated pleural effusion. So there are a lot of reasons and a lot of etiologies for pancreatitis. Most common cause is biliary, meaning a gallstone and gallstone pancreatitis, and alcoholism accounts for 70% of acute pancreatitis cases. So biliary and booze. Hyperlipidemia can cause it. Parathyroid disease we've mentioned. Abdominal trauma, hitting your belly on the steering wheel and crushing your pancreas, or the little kid that hits his pancreas on the handlebars and ends up with a fractured pancreas. ERCP, the very procedure that we use to go down and pull those gallstones out, can also piss off the pancreas and cause pancreatitis, especially if they do what's called a sphincterotomy, where they put a knife in and they open up the sphincter right here to let bigger gallstones out. They put a little tiny probe in here and they make that opening larger, and guess what? That can piss off the pancreas. Pancreatic divisum, which is what we saw in that earlier slide, that can cause pancreatitis. So here's a case of pancreatic divisum where the duct of Wirsong should be the normal major pancreatic duct, is the minor duct. And then the minor papilla, the smaller opening, turns out that it is the main pancreatic duct. So normally you should have a small duct of Santorini and a large duct of Wirsung. But if this opening is too small, the pancreas can't drain appropriately. It gets pissed off and backed up with the amylase and lipase and begins to digest itself. So what about annular pancreas? We'll take a look at that in just a second. That can also cause pancreatitis. So in annular pancreas, this piece right here should absorb when the annular portion of the pancreas swings around and joins. So just like we have here, we have the ventral bud, we have the dorsal bud of the pancreas. The ventral one swings around, and before you know it, it becomes part of the common bile duct. In this case, when it swings around, it leaves a piece of pancreas there and it pinches off the duodenum. That also can cause acute pancreatitis. Sphincter of Oddi dysfunction. There's little tiny muscle fibers around our opening here. And these muscle fibers can be inactive and also inappropriately constrict the opening and cause pancreatitis. Of course, cancer can be a problem, specifically one called intraductal, papillary, mucinous, neoplastic cancer of the pancreas. And I specifically write this one down because the most common cancer of the pancreas is probably adenocarcinoma of the pancreas. But this one has gotten a lot of press lately, especially in the surgical literature. Intraductal, papillary, mucinous. It creates a lot of mucin. So when they put a scope down and do a biopsy, there's a lot of mucus secreting going on here at the opening here at the papilla, the ampulla of Vater. And that's a sign you might have a cancer. And of course, infections of the pancreas can also cause pancreatitis. And then there's something called autoimmune pancreatitis. So let's take a look one more time at what we can see here with some of the common etiologies of pancreatitis. So of course, we've mentioned alcohol, gallstones, low blood flow from shock. There are a couple of medications that can really cause it. Hyperlipidemia, hypercalcemia. Sometimes people get it and we have no idea why they get it. Here's chronic pancreatitis. Chronic pancreatitis is diagnosed and is pathognomonic finding of calcium deposits within the pancreas. This usually means somebody's alcoholic. When someone walks into your office and says, "I'm dying in pain, doc," you run them through the CAT scanner and you don't see any inflammation around the pancreas, but the pancreas has saponified and dropped a bunch of calcium deposition in the pancreas. That's chronic pancreatitis. So over here, they tell us the bile ducts obstructed by gallstones are one of the most common cause of pancreatitis. So here's our stone, it gets stuck in the bile duct, but mostly it gets stuck right there at the ampulla of Vater. Everything backs up. That causes acute pancreatitis. So that is pathognomonic of chronic pancreatitis, not acute. Don't get them confused. And here are the causes of acute pancreatitis summarized. Just take a look at them. We didn't talk about alpha antitrypsin deficiency, vasculitis. I've actually never seen any of these. I've seen lots of chronic pancreatitis and acute pancreatitis. So there's a couple of medications that can bite us. 6-mercaptopurine and azathioprine. These are medications that are often used to treat cancer. They have an evil side effect of causing pancreatitis. Hypertriglyceridemia. This is what it looks like. We spin your blood down and you got a lot of fat in your blood. Levels between 300 and 500, and usually its levels even higher than this of the triglycerides. Usually it's in the thousands. Hypercalcemia, we've already mentioned that. I'm not going to go through this crazy chart, but here are the parathyroid glands. There are usually 4 of them. There can be as many as 9. They're usually adjacent to the thyroid gland in the tracheo-esophageal groove is often where we find them. Sometimes the parathyroid glands are found within the thyroid itself. But these little guys right here, these 4 little glands, are responsible for mediating our serum calcium. So anything that can affect those parathyroid glands and cause hypercalcemia can cause pancreatitis. Cancer, metastases to the bone can cause hypercalcemia and subsequently pancreatitis. and just some other weird things. This one you might see thiazide diuretics can cause hypercalcemia, and these are one of the things that we do think about and check for when patients come in with acute pancreatitis or those thiazide diuretics. This should be a reminder from NMSK course and also from anatomy of the abdominal wall. Physical exam findings here. Cullen sign, which is a bruise around the belly button, and Gray-Turner sign, which is a flank bruise. We can see these. These are usually signs of retroperitoneal hemorrhage, can be seen in trauma, can also be seen in hemorrhagic pancreatitis. We've mentioned this before in other talks. The patient comes in, physical exam findings. Usually the abdomen is distended. Sometimes it's rigid, and they have what's called involuntary guarding, which means their abdomen is like a board. They're not just pushing your hand away. Their abdomen, without anybody touching it, is hard like a board because it hurts so bad and they don't want to move around. And the last thing they want you to do is touch their abdomen. Perfect picture of an ileus. These are intestines in somebody who's sick. They have pancreatitis. The pancreas and the phlegmon and the inflammation and the inflammatory mediators are making the entire intestine sick. So we see intestines that are just full of air. Everything is full of air. Small bowel is full of air. Here's the ascending colon, transverse colon, descending colon, down to the rectum. It's all full of air, and they can't get rid of this air. It's not just like they can have flatus and expel that air. They can't. They come in, their abdomen's distended, it might be tender, and lo and behold, they have an ileus. When someone comes in whose abdomen is rigid and board-like, usually they have a perforation, like a duodenal ulcer. That's pathognomonic for a duodenal ulcer, a rigid board-like abdomen. But they can also have mechanical bowel obstruction, they can have a volvulus, or even, God forbid, mesenteric ischemia, where a clot gets stuck in the celiac trunk or the superior mesenteric artery and kills off all their small intestine. You can see a picture like this in somebody who has thrown a clot that has atrial fibrillation and dumps a clot down into the superior mesenteric artery. Today, almost every patient who comes into the emergency room complaining of abdominal pain will get a CAT scan, but many times they'll get what's called an acute abdominal series, which includes a chest x-ray and abdominal films, flat and upright abdominal films. Here, in someone who has acute pancreatitis, we see something called the colon cutoff sign. It is a poor prognostic sign, and it's created from the edema of the pancreas, which has created so much swelling that it actually causes the colon to be obstructed near the transverse colon, the splenic flexure area, and in the descending colon. Here's a great picture of colon cutoff sign. I don't think you'll normally see it this clear. Of course, the patient will usually come in with some pulmonary infiltrates. Many times that left lower lobe effusion is seen, and this colon cutoff sign is pretty pathognomonic for somebody who has very severe pancreatitis. On this film, they also have an ileus, as you can see from all of the small bowel here. When we look at this plain x-ray of small bowel, we can see the valvulae conniventes here. I think our anatomist will call them something else. And here we can see a little bit of transverse colon with haustra. And then over here, you can see stool through the ascending colon, which is right here. But almost all of this is small bowel. This is colon coming down and around here. So the diagnosis requires, obviously, abdominal pain, suspicious for pancreatic origin. And normally on a series of blood tests, the amylase and lipase will often be 3 times higher than normal. Now, that's not written in stone. It can be a little bit, just a few hundred points higher, or it can be in the thousands. Lipase, again, is the most sensitive indicator with a sensitivity of 92%, much more so than the amylase. And the reason that is because all of these diagnoses here can also have hyperamylasemia. So somebody who has a bowel obstruction, who has intestinal ischemia, Maybe somebody who just has a hot gallbladder. Appendicitis can cause hyperamylasemia. So amylase is not the most sensitive indicator. And of course, our most sensitive diagnostic test is going to be CT scan of the abdomen and pelvis. And remember, that's going to be a dynamic CT scan. Here's another good example. Here we see the aorta. Here is, of course, the left and right crura. Kidneys can be seen, renal vein. This is probably the splenic vein because it's not that typical curlicue, but the arrows are pointing to edema here in the gutter. Here's spleen here. There's edema up here. All of these areas marked by the stars have edema in them, and you can clearly see the pancreas with an area of impending necrosis right here. And the stomach, of course, is full of oral contrast. Here's the gallbladder, and this is a bit of a bad sign. It looks like there's edema also in the wall of the gallbladder. So I'm going to let this play because I think he does a really nice job of explaining the findings of radiology on the pancreas when acute pancreatitis is entertained.
So my name is Albert Parladay. I'm the section head of abdominal imaging at Cleveland Clinic, Florida. And like we said, we're going to talk about the radiologic assessment of severe acute pancreatitis. What I'm going to talk about is first CT scan for acute pancreatitis. This is the mainstay for imaging for acute pancreatitis, so we're going to talk about that first. We're also going to discuss MRI for acute pancreatitis. We're going to discuss the classification and appearance of various pancreatic collections, and I'm going to show you some images of those. We're also going to discuss other complications of acute pancreatitis and their imaging appearance. And then last, we'll touch on percutaneous drainage of pancreatic collections. So first I want to start off with the revised Atlanta classification for acute pancreatitis. I think the most important thing when imaging pancreatitis and when discussing pancreatitis is that everyone's on the same page with the nomenclature, the terminology, so that we can all communicate appropriately and the appropriate management can be made for these patients. In 2012, a consensus group of gastroenterologists, pathologists, radiologists, and surgeons updated the Atlanta classification and came up with new standard, clear, clinically relevant terms to define pancreatitis, necrotizing pancreatitis, and the various collections. And everything I discuss in this presentation and everything I use in practice is from the revised Atlanta classification. So we'll start with a patient. This is a 73-year-old man. He came in to the emergency room with abdominal pain, elevated lipase of 3,000, and an ultrasound showing cholelithiasis. In the emergency room, as is normal, he had a CT scan for his abdominal pain, and it showed CT findings of interstitial edematous pancreatitis. This patient was hospitalized, discharged, and then returned on day 31 with increased abdominal pain, nausea, constipation, and leukocytosis. So on day 31, he had another CT scan and also an MRI. I'm going to pose these questions, but then answer them later on. Just something to think about. Is this necrotizing pancreatitis? Remember, he presented with a CT scan showing interstitial edematous pancreatitis. And what is the appropriate name for this pancreatic collection? Is this a pancreatic abscess? Is this walled-off necrosis? Is this an acute necrotic collection? Or is this acute pancreatic fluid collection? So we'll see the answer later. So we'll start off with when to image acute pancreatitis. As we saw in this patient, he came into the emergency room with severe abdominal pain and he got a CT scan. That's pretty much the normal course. Patient presents to the emergency room with a severe abdominal pain and they're going to want to exclude other possibilities like a perforated ulcer, dissecting aortic aneurysm, and a CT scan is going to be performed. That being said, it's probably not the best time to image acute pancreatitis. You don't need it for the diagnosis, and your sensitivity for necrosis is extremely low on the presenting day. It's not till about 72 hours that most necrosis really shows up on a CT scan. So speaking of CT scans, it's the primary modality for imaging of acute pancreatitis, and it's because it's readily available and reproducible in all centers. You can use oral contrast material. In our institution, we use water. We find that sometimes, especially as we make efforts to reduce radiation, barium in the stomach or gastrografin in the stomach can cause some artifact through the pancreas, so it can limit evaluation of the pancreas. So we use water for distending the stomach, duodenum, and we don't use a positive density contrast material. IV contrast is essential. This is essential for diagnosing necrosis and looking for vascular complications. You can image the pancreas in various phases. You can do a non-contrast CT scan, then inject IV contrast, in about 35 to 45 seconds, scan again, get a pancreatic parenchymal phase, wait a little longer, 70 seconds, get a portal venous phase. The pancreatic parenchymal phase is the most important phase for evaluating the pancreas. This is when you get peak enhancement of the parenchyma, and when you're going to see the greatest contrast between a necrotic area and a well-enhancing, viable pancreatic tissue. The portal venous phase is important because this is when we get best enhancement of the portal vein, superior mesenteric vein, and splenic vein, and it's going to show us most of our venous complications. The non-contrast phase is sometimes used, people say you need it to evaluate for hemorrhage and necrotic collections, but it very rarely adds information, and it is another multiple of radiation. You're scanning the patient a whole third time. So it's something to think about, something to maybe avoid, and especially in younger patients, not to do it at all. MRI, it turns out, is just as good or better than CT scan for looking for necrosis and its complications, or it can be just as good. It's also helpful with an MRCP to detect choledochal lithiasis that a CT scan won't detect. And it's very useful for characterizing collections. It can identify solid and semi-solid components in a collection and gauge how difficult it might be to drain them. It's especially useful when patients have a contraindication to iodinated contrast material. If they have an allergy, if they're pregnant, or if they're mild renal failure, an MRI is definitely a good alternative for those patients. And it doesn't have ionizing radiation, so it's something to really consider in young patients or in patients that have had multiple CT scans in the past. MRI does have limitations. Number one, it's not always available right when you need it. I know in our hospital, our inpatients are always fighting for time on the scanner, so that's something important. Second, the quality of MRI can vary. It can vary from center to center, and it can vary from patient to patient. The good thing about CT scan, it's very reproducible. MRI, if you have a patient that can't hold their breath, has a lot of ascites, has some metallic implants, you're going to have limited quality MRI. And it also poses a challenge when you're trying to monitor critically ill patients in a scanner. The first thing we use CT scan for in severe acute pancreatitis is for diagnosing necrosis. And here is two examples of necrosis. On the image on the left side of the screen, you'll see, I don't know if there's a mouse, no. There's no mouse. You'll see that there's a little necrosis, an enhancement of the tail of the pancreas. You can see there's a brighter area in the tail of the pancreas, while the rest of the pancreas is low in attenuation. And that's how you diagnose necrosis. You have a contrast-enhanced scan, any areas that are low attenuating. If you want a number, you can measure less than 30 Hounsfield units is the area of necrosis. You can see that the pancreas on the left side of the screen is about at least 50%, 30 to 50% necrotic, and the pancreas on the right side of the screen, you only see a little bit of enhancement in the tip of the tail, so that's more than 50% necrotic. The classification of pancreatic collections is something important, something that was important in the revised Atlanta criteria, and something to look at. I think it's very simple, and if radiologists look at this and are consistent, then it can be used to guide management. So first you decide whether the patient has interstitial edematous pancreatitis or necrotizing pancreatitis. If they have edematous pancreatitis and it's been less than 4 weeks, you have acute pancreatic fluid collection. If it's been more than 4 weeks, you have a pseudocyst. After 4 weeks, you have a well-developed wall, well-organized collection, and it's considered a pseudocyst. Similarly, in necrotizing pancreatitis, if it's been less than 4 weeks, you have an acute necrotic collection. It's not a well-formed collection. And after 4 weeks, it's called walled-off necrosis. All of these 4 collections can then be subclassified as sterile or infected, and you can see how classifying appropriately can guide management. Here's the patient from the beginning of the lecture, and the first question was, is this necrotizing pancreatitis? And if you look at the image, you can see there's a little bit of enhancement in the pancreatic tail, the body and head of the pancreas. There's no identifiable enhancing pancreatic tissue, so this is necrotizing pancreatitis. So even though he was imaged on day 1 and showed no necrosis, we know that day 1 has a low sensitivity for necrosis, and this is necrotizing pancreatitis. Now, what kind of collection is this? This is a pancreatic abscess. He presented with leukocytosis, and the answer is no. Pancreatic abscess is not one of the terms used in the revised Atlantic classification. It was decided that that was a confusing term. It didn't distinguish between necrotic collections and simple collections, and so that was eliminated from the nomenclature. This is walled-off necrosis, and it may be infected. And you can see the image on the MRI below it. You can see how complex that collection is. It doesn't have the simple fluid T2 signal that we see in that renal cyst on the bottom. Instead, it has a very dark signal, very heterogeneous signal, and this looks like something that would be a challenge to drain. Here's another patient. This patient CD. This is week 6 after presenting, and you can see the difference in this collection. On CT scan, it's very homogeneous. It has a few little complexities, but it's almost entirely fluid density. And on the MRI, this very bright on T2. Again, a little bit of debris in it, but it's a very well-formed wall, bright T2 signal. This is a pseudocyst. On the CT scan, you might ask, is the body of the pancreas necrotic? But if you scroll up and down the images, you'll see that the fluid collection is actually compressing and displacing the pancreas rather than replacing it. Here's another patient. This is on day 1. This patient presented also with interstitial edematous pancreatitis. You can see the pancreas is swollen, some stranding around it, but it is still enhancing. So this is not necrotic at this point. This patient had a very complex course, and on day 33 looked like this. You can see there's a very heterogeneous collection. It has gas in it, and it has an enhancing wall. So this is walled-off necrosis. Again, another MRI showing how complex this fluid is. It doesn't look like something that's going to drain easily. It's got many different signals in it, very heterogeneous. Includes some fat signal and some gas. This looks like something that would be a challenge to drain. But the patient was very sick, not a very good candidate for rushing to the operating room because of how sick he was. We put a drain in, and he started to get better. You can see the collection got a little smaller. You can see the percutaneous drain. So even though it was a challenge to drain, it's sometimes the best choice. So when do we drain necrotizing pancreatitis? And really the indication is suspicion for infection. So a patient is clinically deteriorating, has developed a fever, has an elevated white blood cell count. We know they have necrosis, and we see a collection on CT scan. These are the best candidates for drainage. If there is any question as to whether or not the patient has infection or we want to avoid drainage for whatever reason, you can put a needle in it, try needle aspiration first, and that'll prove that there's an infection. But the goal is really to temporize a critically ill patient with the least invasive procedure. And it's very effective. It can bridge patients to elective surgery later on or endoscopic drainage if needed, but some patients actually get better just with the drain. The one thing to keep in mind is that these pancreatic collections are very complex, very viscous. They have solid components, and they can be very difficult to drain, so they require more attention than other types of collections. You may have to place multiple drains, you may have to go back to drain multiple times, and it's going to require aggressive irrigation and probably repeat imaging to see how well it's draining and whether or not more drains have to be placed. So there's other complications of necrotizing pancreatitis that we pick up on CT scan and can evaluate for on CT scan. These include GI and biliary complications, solid organ involvement, vascular complications such as pseudoaneurysms and venous thrombosis, and pancreatic duct complications such as a pancreatic duct stricture or disconnected pancreatic duct. I'm just going to show some examples of a couple of these. The first is a splenic artery pseudoaneurysm. And you can see this very brightly enhancing mass near the splenic hilum with a surrounding fluid collection. And on the coronal image, you can see how it is arising from the splenic artery. So this is a splenic artery pseudoaneurysm. This is probably best seen on the pancreatic parenchymal phase because that's an arterial phase essentially. So this is when you're going to see the arterial problems. And then this is another example of a complication that I wanted to discuss because it's not a common complication. I've never seen it in practice, but something to always keep in mind. This is from the literature, this example, but whenever you have necrotizing pancreatitis involving more than a 2-centimeter segment of the pancreas, and you have upstream functioning parenchyma, you're at risk of disconnecting the pancreatic duct or necrosing the duct itself and having constant leakage from the pancreatic duct and forming a fluid collection. So whenever there's necrosis and a fluid collection, this is something that should be considered. You can have an MRCP. I've seen some MRCPs where I can very carefully track the duct and see that it's intact. But if you cannot see it clearly on MRCP, this is something to worry about, and the way to diagnose it would be with an ERCP where you would see active extravasation like in this image here. It's important to identify this because most of these patients eventually need surgery. So in summary, contrast-enhanced CT after 72 hours is the mainstay for diagnosing severe acute pancreatitis and its complications. MRI can add information and is an excellent alternative when contrast-enhanced CT is contraindicated. Pancreatic collections are best classified by time course of disease, presence or absence of necrosis, and presence or absence of infection. And percutaneous drainage of infected pancreatic collections is more challenging than for other types of collections, but is an important tool in our treatment. Thank you.
I hope you watch the video because I really think he does a good job of going through the salient features of CT scanning and also MR scanning of acute pancreatitis. Now we're going to look at some of the rating systems for pancreatitis. I don't expect you to memorize these, but I will tell you what I want you to know from them. There is a CT rating system where you can tell just based on how the pancreas looks on CT scan, how we would grade it. Grade A through E, and of course we would score it over here, how much pancreatic necrosis you'd have. And then so you have the CT grading score, this right here, plus the score of necrosis. And it gives you a 0 to 10. If you were to go back and look at some of those images that the gentleman from Cleveland Clinic just showed us, you'd get a good idea of how bad some of those pancreatic necrosis collections really are. What is the purpose of our classification systems? Well, it allows us to give the patient an appropriate level of care based on how bad their pancreatitis is. Pancreatitis, especially gallstone-induced pancreatitis, is one of the most common diagnoses that a general surgeon would see. It's also a common diagnosis in a hospital setting, but not everybody comes in with pancreatitis that is that severe. Sometimes they have a gallstone that has occluded both of the ducts. The stone is spit out, and their pancreatitis resolves within 2 or 3 days. So if we can talk among ourselves and come up with a consistent grading scheme, we can triage our patients much better. And this will allow us to grade and somewhat predict the all known and all catch here of mortality. Ranson's criteria is something that I don't know that you need to memorize verbatim, but you should know there are a couple of things that you might think that would be on this that aren't. One of the things that our scales do is they allow us to compare patient outcomes between the different clinical diagnoses and series the patient presents with. Now let's look at Ranson's criteria. This is an unpopular but time standard and time tested system for grading pancreatitis. It was founded in the 70s, as I mentioned, and I gave you that original paper. Notice, age greater than 55, white count greater than 16, glucose greater than 200, an AST greater than 250, and an LDH greater than 350. This is on admission. And then 48 hours later is the calcium less than 8. The hematocrit falls, meaning there might be a hemorrhagic component to the pancreatitis. Is the oxygen PO2 less than 60? Are they hypoxic, contributing to an ischemic pancreatitis? Does the BUN increase greater than 5 points? Is their base deficit greater than 4 milliequivalents? And have we given them more than 6 liters of fluid in the previous 48 hours? Based on how many of these criteria that they have, we can calculate their mortality. What you notice that's not here is a serum amylase or a serum lipase. What we use to measure how bad and how pissed off the pancreas is when the patient comes into the emergency room isn't even included here. Amylase and lipase are not there, but oddly, AST and LDH, glucose and white count are. You should at least be aware of that. So if you want to click on the criteria, you can on the PowerPoint. We won't do that again. But it is considered outdated, and it's hard to come up with those numbers after 48 hours. It's hard to define what 6 liters of fluid sequestration is. Does that mean I had to give them 6 liters to get their blood pressure up to normal, 6 liters to get them to make urine, or 6 liters is what I just happened to give them based on my IV rate? It's not that clear, but we'll need it a little bit later to look at our case that I'm going to present here. So here is a review article of the prognostic scores in acute pancreatitis, and I think this is a 2015 paper. It's relatively current. So another staging system that we use for acute pancreatitis is called the BISAP, Bedside Index of Severity in Acute Pancreatitis. It's pretty simple. They get a point each for each of these. If the BUN is greater than 25, if they have an impaired mental status, if they have systemic inflammatory response syndrome, if their age is greater than 60 years, and if they have a pleural effusion. They get a point if they have any of those. And that is the ease of use of this grading system. It's reproducible, and this is probably the most common and most preferred. Of course, there's the Atlanta classification, which the gentleman from Cleveland Clinic in Florida did allude to. He said that there was a revised Atlanta classification. If you want to go read all of it, you can. Go look at the PowerPoint that accompanies this video, and you can look at it. Don't memorize this, please. Just know that there are several indices here that we use on the Atlanta classification to define where the pancreas is pissed off and how bad it's pissed off. Is it just acute pancreatitis? Is it mild? Is it severe? Does it have more than 3 Ranson criteria? Interestingly, our Atlanta classification includes Ranson's criteria. Is there a fluid collection in or near the pancreas? Is there non-viable pancreatic tissue diagnosed on a dynamic CT scan of the pancreas? Is there a pseudocyst? And of course, he told us we don't use the term pancreatic abscess anymore, but I think that's probably not everybody. So let's look at the case presentation. We got a 64-year-old guy comes to the hospital with a 4-day history of progressively worsening epigastric pain, doesn't radiate. He's got nausea, vomiting, and a little short of breath, and there's no history of abdominal trauma. His pain is constant, and it radiates right to his back. That could be a peptic ulcer. That often is seen in a peptic ulcer where patients come in and have upper epigastric pain boring right to the back. It started after he had some pizza and beer and got progressively worse over the past 4 days. He vomited 3 times. He's had some indigestion in the past, but he said never like this. And he tried some over-the-counter Pepcid, some Mylanta, and he even tried some non-steroidals, and it didn't help him at all. No significant past history. His colonoscopy was normal 5 years ago. And believe it or not, he doesn't take any medications. Heavy smoking history, a pack a day for 40 years, and he admits to being a pretty heavy drinker. That puts him at risk for acute pancreatitis and also for chronic unrelenting pancreatitis with those pancreatic calcifications that we'll look for when we see his CAT scan. He denies any illegal drug use, and his family history didn't tell us much. So he's got a fever. That's a bad sign. 101.3. His blood pressure is 120/70. Thank God he's not in shock. He's a little tacky at 100. His respirations are 18. When we go in and look at Grandpa, he's lying still. He's in a moderate distress. He's not jaundiced. His eyes are not jaundiced. His respiratory rate, as we said, was 18. His lungs are clear. That's interesting. If he had that left lower lobe effusion, we might hear some crackles in that left lower lobe. His cardiac exam was basically normal. So when we examine him, he's got this big round tummy. He probably has an ileus going on. It's moderately distended. He's tender in the mid-epigastric region up here, and his right upper quadrant, interestingly. No rebound, but he has voluntary guarding. So when we touch him, he pushes back against us. He doesn't want us to push any harder. No masses, no bowel sounds. So things are pretty quiet. No bruising. What am I looking for here? I'm looking for colon sign or gray turners, which could be an indication of a hemorrhagic pancreatitis. No costovertebral angle tenderness, which could be a sign of pyelonephritis. His extremities looks okay. Rectal exam was negative. So let's do some labs. We get these back. We see that his hemoglobin's pretty low. He's anemic. His white count is high. His potassium is low from vomiting. His BUN is okay and his creatinine's okay, thank God. His liver enzymes, his AST is a little high. His ALT is a little high. His total bilirubin is twice normal. His ALK-Phos is 110. ALK-Phos is the blood test which is most used and most indicative of some sort of biliary obstruction. And of course, the total bilirubin is really can be used for that too, but we need an indirect and an indirect bilirubin to break that down, and we don't have that here. So indirect or direct is known as conjugated, indirect is unconjugated. His amylase is high at 326, his lipase is high at 245. Everything else looks okay. His LDH is 375. So we already have some of Ranson's criteria that we can plug in here based on this. Interestingly, he's been vomiting. He's hypokalemic. He might be hypokalemic, hypochloremic, metabolic alkalosis, but we're not totally sure. He could be acidotic if he has any underlying sepsis. So what kind of inflammatory mediators do these guys have that have systemic inflammatory response syndrome? COVID, the virus which is killing people all around the world, is so feared because it causes a systemic inflammatory response syndrome. It also causes what's called shock lung, ARDS, acute respiratory distress syndrome. COVID causes these inflammatory mediators in the lungs too, which makes it so deadly. So what are some of the inflammatory mediators that we can measure? Well, granulocyte polymorphonuclear neutrophil elastase. Never ordered it in my career. Tumor necrosis factor, I used to test for that when I did some research on lab rats, but I never ordered that either. Interleukin 6, interleukin 8, I know about them, but never ordered those clinically either. But I did order C-reactive proteins. This is the most useful inflammatory mediator. If it's greater than 150 milligrams per deciliter within 72 hours of the onset of the pancreatitis, it defines severe pancreatitis. C-reactive protein and lipase seem to be the two things that we were looking at. So along this line, we start with systemic inflammatory response syndrome, work our way to sepsis, worsening sepsis, and then shock with hypotension. So our differential diagnosis of Grandpa when he comes in: cholecystitis, choledocholithiasis, a stone in the common duct, a peptic ulcer that has perforated. Maybe he's just got gastritis from drinking all that beer. Of course, pancreatitis, that's what this lecture is about. Could he have a bowel obstruction, ischemia, gastroenteritis? Could he have hepatitis, appendicitis, any or all of these? Yeah, he could. So what we're going to do is we're eventually going to get to a scan because we know he's going to need that. But he probably has, as I mentioned, hypokalemic, hypochloremic, metabolic alkalosis. He's got an elevated amylase and lipase, which is consistent with pancreatitis. And on admit, He's got 4 or 5 Ranson's criteria. There are 6 more Ranson's criteria that we're going to have to look at over the next 48 hours. So can you list them? Sure, if you pull out your iPad or your phone. Do I want you to spew them back at a test for me? No, but I might make a test question that says, which of the following are not part of Ranson's criteria? And that, of course, would be amylase and lipase. Can we rescore this patient using Atlanta criteria? Here's the Atlanta criteria. Sure, we can go through here and measure these and see what he's got. Here, of course, is Ranson's criteria. We might want to look at this and correlate and see exactly what grandpa's risk factors are. So Ranson's prognostic signs that correlate with the risk of major complications or death, mortality, right down here. So if you have 2 of Ranson's criteria, 2 criteria, 2% mortality. If you have 7 to 8, you got 100% mortality. And we just counted 5 just on admit. So our boy right here has got a 40% mortality just based on his first admit labs. So note that the amylase and lipase are not prognostic signs, and they do not relate to the severity of the attack or the prognosis. You will see amylase and lipase levels in the thousands, and I mean 10, 20, 30,000. You will see them that high. And most of those are associated with pretty impressive pancreatic phlegmons, but not all of them. They don't have to be. And you must usually order your LDH separately because it doesn't usually come with the Medicare defined blood test called the CMP, or our liver function enzymes. And here is what a saponified pancreas looks like. So all of this white stuff here is saponified pancreas with calcium deposits within the body of the pancreas itself. So our interventions at this point for grandpa, he's in the ICU. We're going to give him a couple of liters bolus of lactated ringers or normal saline, pretty high, 150 cc's an hour. We're going to titrate it until he starts making pee. We're not going to feed him because if we feed him, it might piss off the pancreas more. We're going to put a catheter in his bladder, and that's going to help us not only measure his urine output, but as I mentioned earlier, I might have to use it to measure an intra-abdominal compartment syndrome to rule out and make sure that that doesn't develop in this patient if he has such a severe inflammatory response going on in his belly. Should we put a tube in his nose? Maybe. I will tell you that in my patients, I preferred that they get a nasogastric tube in their nose, down in their stomach, to suck out all that fluid and make their ileus a little better, because they're already nauseous. They already feel like they're going to vomit. Let's put a tube in and suck their stomach out and make them feel better. But remember, when we suck his stomach out, we're going to be sucking out acid, and we're going to be sucking out potassium. So we need to replace his potassium because he's already hypokalemic. Just a couple of things that we can do. If we realize on his initial CAT scan that he's got necrotizing pancreatitis, if it's not infected, we can watch it. We don't have to necessarily do anything. If it gets really bad, or if it becomes symptomatic, meaning with a fever, we might have to drain it or debride it. If right away it's infected, and our boy had a fever, don't forget, and he had a white count, but he was hemodynamically stable, we can watch it. We can see what happens. If he gets worse, then we're going to have to go in and debride it. So which imaging study should we do? We just listened to the guy from Cleveland Clinic. He said a CAT scan. Sounds to me like that's probably what we should do. He's probably going to get a flattened upright of his abdomen. He's going to get a chest x-ray when he comes in. Remember, we're looking for a left lower quadrant pleural effusion. We're going to do an ultrasound looking for gallstones. You say, well, can I see the gallstones on the CAT scan? Ultrasound is more sensitive for gallbladder disease than is CAT scan, okay? He doesn't need a HIDA scan. He doesn't need an MRCP yet, and we might get an EKG on him based on age and epigastric abdominal pain. He could be having a heart attack. We don't know. So let's take a look at this ultrasound of the pancreas. I love the fact that you guys are getting ultrasound training and you can sort of make out what's going on here. So let me show you what we're looking at. Here is the left lobe of the liver right there. And here is the pancreas. I'm going to draw a circle around the pancreas so you can see this. Here's a big dilated pancreatic duct right there. Here is probably some sort of cyst in the pancreas, which got some junk in it probably needs debrided, whatever this is. It might be a pseudocyst. We've got something else here in the pancreas too. I don't know what that is. We're going to have to do a dynamic CT and see if that's a tumor. So here's the pancreas. Okay, common bile duct is right there. Here's a dilated pancreatic duct. Here's our pseudocyst and maybe a tumor. So hopefully you guys can see all of that. So now let's make some decisions. Let's do an ultrasound of his right upper quadrant, and that's indicated to look at his gallbladder and his bile duct to see if there's any stones. The way we order this in the hospital is we'll order an abdominal ultrasound. That way they'll include the kidneys in it too, and we'll be able to see whether he has any underlying hydronephrosis or if there's a renal cause to his abdominal pain. We know that we're suspecting, based on his blood test, his fever, that he probably has pancreatitis and the fact that he likes a lot of beer with his pizza. So we're going to do a CAT scan, but that should be done after we've stabilized him. We might have to give him a lot of fluid, some antibiotics to help his fever, and then we can send him down for a dynamic CT scan of the abdomen and the pelvis. Remember, we're going to order what's called a dynamic pancreatic CT scan. So if we can look at this CT over here, we're going to see a pancreas, which you can make out there. This is an area in here which is not lighting up, so there's edema here. There's this probably small pseudocyst. This looks like colon, splenic flexure of colon. Here's the spleen, the kidney. Here's gallbladder. Here's aorta, vena cava. Right here is probably portal vein, although it could be duodenum full of fluid, not 100% sure. And of course here we have the right kidney. So when is a CT scan ordered? Well, if we listen to our buddy from the Cleveland Clinic, Florida, he told us that if our patient has severe signs of acute pancreatitis, and if there's no clinical improvement, and if there's a fever and he has positive blood cultures. What kind of CT scan? Dynamic CT scan with a rapid bolus of IV contrast. What are we looking for? We are looking for lack of enhancement. So that portion of the CAT scan that lights up, that means it's getting contrast, and that by deferral means that he's getting blood to that. If it doesn't enhance with contrast, that's dead pancreas. So let's take a look at his initial scan. Here's our boy. We've got pancreas here. We have a pretty good sized phlegmon. This is a pretty good pissed off pancreas all the way here. So let's draw retroperitoneum. Comes up here, and it's going to come up all the way up here and around. He's got fluid down here in the splenic gutter. This does not enhance, but this could only be within 3 days. So I'm not 100% sure if this is just edematous fluid surrounding the pancreas or it's potentially dead, inflamed pancreas. At this time, I'm going to bank that this is just pissed off pancreas, and we still don't know whether this is going to need debriding or not, because most of the pancreas itself looks okay. I don't see a dilated duct. Here is the opening in the duodenum, of course, aorta, cava, and then of course here is the portal vein. Here's liver, kidney, and diaphragm with some retroperitoneal pararenal fat. So what we're going to do, first of all, we're not going to feed him, because if we feed him, it's going to cause the exocrine and endocrine functions of the pancreas to kick in. We don't want the pancreas, which is already pissed off, to get any worse. So if we feed him by mouth, we're going to stimulate pancreatic secretions. Sometimes we give our patients somatostatin, but that has never actually been shown to decrease morbidity or mortality. We give somatostatin to try to slow down the pancreatic juices. We might want to give him some fluid and electrolytes. He might need a ventilator depending on how hypoxic he is. If I remember, a PO2 of 60, which was pretty bad on Ranson's criterion. I don't know what this guy's PO2 was. I don't remember. Nutritional support. Well, if we're going to feed him enterally, if we're going to feed him anything down his gut, we need to make sure that our feeding tube goes past the duodenum, preferably past the ligament of Treitz, so that we can feed the jejunum. We don't want to feed anything in the stomach that will cause the stomach to distend and then cause an increase in acid production, an increase in gastrin, and then that in turn would stimulate the exocrine function of the pancreas because the pancreas is already pissed off. So we can fake the body out by feeding it distal to the ligament of Treitz, distal past the ampulla of Vater and where the duct of Wirsong or the duct of Santorini come in into the duodenum. We might want to give them some PPIs, things like intravenous Nexium or intravenous Protonix to drop the acid secretion in the stomach because we don't want him to get a stress ulcer. He's going to be in bed. We want to make sure that he doesn't get a blood clot in his leg. Should we give him antibiotics? We're going to talk about that. At this point, we probably won't, but this guy's got a fever. So I could make the argument I'd give him some antibiotics based on what the organism is that has most likely invaded his pancreas. But it also could be sterile. So this is sort of iffy. And of course, we're going to give him some pain medicine. One thing I would like to show you, there's oral feeding compound called Vivanex. This is an elemental pre-digested diet. This is the stuff that you can give past the ligament of Treitz. Remember that name, Vivanex. You're going to hear it when you're an intern. And over here we can give intravenous lipids, and this contains our amino acids, and the reason it looks yellow like urine is it contains amino acids and vitamin products. So if our patient came in and had hyperlipidemia, and I don't remember if we ordered a big lipid profile on him or not, but if his pancreatitis was caused from hyperlipidemia, I probably don't want to give him any intravenous lipids. So amino acids, 4 calories per gram, lipids, 9 calories per gram. And Vivanex we can feed orally. We can use the gut to feed him. The reason that the gut is preferred to feed people is we want to keep our little villi happy. If we don't feed the gut, the villi will atrophy, and it actually is detrimental for the absorptive surface of our small bowel. Here we are. We're in the ICU. The patient deteriorates with non-operative treatment. Now he's getting high fevers. He's got hypotension. What's going on? Sounds like our boy's getting septic, that those inflammatory mediators are going up and over that curve. He might be going into acute respiratory distress syndrome. He might have systemic inflammatory response syndrome. Now he's going to probably need antibiotics and more IV fluids. Here's our boy when we scan him on day 3. Now we can see the pancreas is really pissed off. It has air in it, which means it has air and gas forming organisms in it. It is well contained and well walled off. So we're not going to call it a pancreatic abscess. I probably would anyways, but this is definitely pancreatic necrosis, which is now infected with a gas forming organism. Here is our right kidney. Here is what is some inflammatory fluid around our left kidney. Of course, here's just a little tip of the liver that we're seeing, and we're down too low. We're past the spleen in this picture. So this boy is going to need some drainage of this pancreatic phlegmon, this infected necrotic pancreatic mess that we see here. So now what? Well, let's either call our interventional radiologist to stick some big drains in here, or we might need to go to the operating room, open him up, and scoop the stuff out with an ice cream scoop. So the number one determinant of whether our boy survives or not is whether that pancreatic tissue is infected, and I'll bet that his is. So infection is demonstrated by air in the retroperitoneum or the lesser sac. Infection can occur without air. And if you suspect it, you might want to stick a needle in it. But if you stick a needle in it and it's sterile, you may just infect somebody's sterile pancreatic collection, and now you've doomed them to get an infected pancreatic collection. And caution is always warranted because you could stick the needle through colon or stomach, and once you've done that, you're going to infect that pancreas. In this case, here we're just reviewing some anatomy on how to get to the pancreas. We can either stick our finger in the epiploic foramen, where you see this wire going through here into what's called the lesser sac, or we can cut off the omentum that hangs off the inferior aspect of the stomach, raise the stomach up, and we can see the pancreas here in the lesser sac. Here, of course, the greater sac, also known as the peritoneal cavity, is located here by those arrows. So in this nice pretty picture here, we have stomach, lesser sac back here, Of course, we have superior mesenteric vein, superior mesenteric artery, just a review of the anatomy. So our 4 treatment goals, this was one of our learning objectives. What are our 4 treatment goals for pancreatitis? 1, supportive care. Give them IV fluids, provide some sort of nutrition, do everything that we can to stay out of this person's abdomen. Minimize or reduce the necrosis and minimize the associated systemic inflammatory response. Treat the local complications of the disease. We can treat the peripancreatic fluid collections as long as they're not infected, and we're not going to infect them. What if they have an abscess? Well, we're going to have to go in and fix that. If they get a pseudocyst, we're not going to do anything with a pancreatic pseudocyst. We're going to give the body 6 weeks to wall off that pseudocyst so it can become what's called mature. And once we get a mature pseudocyst, that's good. We can usually watch those. They don't do anything. Once in a while, we might have to drain a pseudocyst. And there's a video clip showing you how to do that. And of course, if there's any biliary or gastric obstruction, we're going to have to take care of that with an NG tube. If there's biliary obstruction, we might have to do an ERCP and pull any of those gallstones out that are blocking the common duct or the pancreatic duct. And we need to identify the cause of the pancreatitis so we can prevent subsequent episodes. Remember, hyperamylasemia is usually a sign of pancreatitis, but there's a lot of other things that can cause a high amylase level. So, patients who are not infected should not be operated on. So if a patient has a large pancreatic phlegmon, it doesn't have air in it, they're not having fevers, then let's not operate. If they are having fevers, that might just be from the systemic inflammatory mediators. It may not be from infection. So it's a clinical judgment. In this paper here by Edward Bradley, he says neither the existence nor the extent of the necrosis can be used as an indication for surgery. 90.4% survival in patients treated conservatively who had over 50% of their gland that was dead but no infection. And I will tell you, you can download this by double clicking on it. I will tell you that locally, when I've spoken to the pancreatic surgeons here in Phoenix, they have told me that they do everything they can to not operate on these patients. It used to be much easier to make the decision to operate, but not so much anymore. So what next? Supportive treatment. Take out the gallbladder if it's causing the pancreatitis secondary to gallstones. When do we do this? Well, this is always a subject of argument. When I was in practice, I waited for the amylase and lipase to normalize. I waited for the liver function enzymes to come back down to normal, which usually took 2 or 3 days, and then I took them to the operating room and proceeded to do a laparoscopic cholecystectomy. We can do a MRCP to see if there's obstruction of the common duct, and if the MRCP shows obstruction of the common duct, they might need an ERCP to take out that stone and open up that common duct. And of course, it's a judicious decision whether we need to go to the operating room or not, and whether or not they're infected. So should we use antibiotics or not? Take out a quarter, let's flip it in the air and see what we should do. The use of antibiotics is hotly debated. The mortality does not seem to change significantly, but there is a lengthening of time to develop infection with the use of antibiotics. So when we use antibiotics, we could do nothing except making our organisms more resistant to the antibiotic that we're using. Antibiotics is something that we used to use. Big gun drugs like meropenem or Invance or imipenem. These were big gun drugs that killed everything. They wiped out the city block, and they also caused usually a fungal infection secondarily. Ciprofloxacin plus Flagyl are 2 drugs that we commonly use to treat pancreatitis, or meropenem or imipenem, but not so much today. We can start them on broad-spectrum antibiotics, which is what these are. We can take them to the operating room and debride it. We can take out their gallbladder if that's it, or we can put in great big giant drains and drain out that pancreatic fluid. We can also put in a feeding tube, and I'll show you the difference between those here in just a second. So our operative management includes to debride and drain all of the dead pancreas, all this necrotic pancreas. Here's a CAT scan showing air in the pancreas, great big giant pancreatic phlegmon. Everything is pissed off in this guy's abdomen. Mortality by doing this, 13.9%. 58% of patients can be treated with one surgical procedure. But that means about 30 to 40% will need more than one operative debridement, which means we'll have to either stick in more drains or sew a zipper in. You heard that right, sew a zipper. So debridement and packing every couple of days, that gives us a mortality of about 10 to 15%. So you want to watch this? Click on this YouTube.
Hybrid laparoscopic endoscopic cysgastrostomy. And
So it's only a 6-minute video, but this guy shows it and he walks you through it, how they drain a pancreatic pseudocyst. Here's another video which I won't play for you and make this video any longer. Please watch it on the PowerPoint if you want to. The same with these 2 other YouTube videos that show you how these cysts can be debrided using endoscopy and or percutaneous laparoscopic means. We don't always have to go and split somebody's belly open like we used to and take an ice cream scoop and scoop out that dead pancreas. They're good videos and they reinforce what I'm always trying to show you. This is a procedure called a Pusteaux procedure, and it is really indicated for people who have chronic calcific pancreatitis. Those people come in with unrelenting abdominal pain, and no amount of opioids or morphine or oral Dilaudid or oral narcotics of any strength can help these people. What is done is the pancreas is debrided wide and open. The pancreatic duct is open wide, and then a piece of intestine is sewed directly to the pancreas so that now the pancreatic secretions drain directly into the intestine instead of through the ampulla vata or the sphincter of Oddi. This is a Whipple. This is a pancreaticoduodenectomy. And you can see here how it required reattachment of the common bile duct, sewing the head of the pancreas to a piece of small bowel after resecting the head of the pancreas. Here's the superior mesenteric artery. Here is the superior mesenteric vein. And of course the stomach is now reattached to the duodenum, called a duodenojejunectomy. So here's a little piece of duodenum, a little bit right there, sewn to the jejunum. Here's a pancreaticojejunostomy, and here's a hepaticojejunostomy where the common bile duct is sewn. A Whipple procedure really would be done if there was cancer in the head of the pancreas, procedure that required us to completely remove the head of the pancreas. Most general surgeons pride themselves in having done Whipples. In 20 years, I never did a Whipple. I never had a patient who needed one, and once I got in, if it was done for cancer and had planned on doing a Whipple on them, usually it was an unresectable cancer of the pancreas, so I didn't proceed. So, temporary abdominal closures. Yep, if someone has acute pancreatitis and we need to go in and debride them multiple times, we will sew in a zipper. You saw it right there. Sometimes patients will have abdominal compartment syndrome. We leave the abdomen open and put a Whitman patch in. And this is an absorbable or a non-absorbable mesh, so that when we go back to the operating room, we can just take this mesh off, expose the intestines, and go back in without having to completely close the abdomen, go back, open it up, close the abdomen. When we do that, it rips up the fascia, and we can't close the abdomen because the fascia is what we use to close the abdomen, and if we keep closing it, we're going to rip it up and won't be able to use it at all. So here's Grandpa. He was slowly weaned from his vasopressor agents after his hypotensive episode. We kept him on a ventilator. We started his tube feedings 2 days after his debridement, and eventually after 4 months he was able to go home. So the summary of treatment of acute pancreatitis: determine where he is going to be at on a pancreatic grading scale. You can use Ranson's, you can use BISAP, Atlanta, we don't care. You might want to put an NG tube in to make his ileus better. Now, here's a nasogastric tube. It's pretty big. This has a sump on it, so it's open to air. I'm sorry, the blue thing here is the sump. This part right here, the nurses will connect to wall suction and suck out all of the stomach contents through this right here. This is the sump that's an air vent, so it doesn't always percolate over. But look at what an oral feeding tube is. We can begin oral feedings, but remember, we need to feed them past the ligament detritus into the jejunum. And here is what a tiny Dobhoff, D-O-B-H-O-F-F, a Dobhoff tube is. Patients have actually put these in themselves. You can see it right there in the back of her throat. This is a feeding tube. I took this picture from the internet because women were actually putting these in trying to lose weight and living off tube feedings. But this is a Dobhoff, and the tip of this tube should be all the way down past the stomach, past the duodenum, and into the jejunum. This is a tiny tube. This is a much larger tube. Nasogastric tube versus jejunal feeding tube, or a Dobhoff tube, same thing. We need to monitor and maintain his intravascular volume, support him nutritionally, support him with a ventilator if they need to be, selective use of antibiotics, and if we suspect that he's septic, secondary to the pancreas having gas-forming organisms, we're going to have to go in and aggressively debride. And remember, surgery only for infected pancreatic necrosis. So let's take some test questions here. When considering the severity of acute pancreatitis, which of the following correctly describes the existing scoring methods? Okay, well, without reading all of them, the complexity of Ranson's criteria is what hinders his general clinical applicability. All of these others are not true. So the Apache 2 Ranson scores, Glasgow scoring systems have fallen out of favor. No, they haven't. So blood, urine, and sputum cultures return negative for our patient. Right upper quadrant ultrasound is not concerning for cholecystitis. Fine needle aspiration of the pancreas grows enterococcus, and we start broad spectrum antibiotics. Which of the following methods of treatment is not adequate treatment for infected pancreatic necrosis? Antibiotics alone? Nope, we know that that is not adequate treatment right there, because we need antibiotics and we have to drain that mess of infected phlegmon before our patient gets better. So all of these others are true. Using antibiotics only is not true. 55-year-old man presents to the ED with a one-day history of worsening epigastric pain, nausea, and vomiting, and has radiographic evidence of focal pancreatic inflammatory changes. He's otherwise normal. He's admitted for fluid resuscitation. Which of the following is true regarding the determination of the severity of acute pancreatitis? 50% of people who die of pancreatitis do so within the first 7 days. That is a true statement. 45-year-old man is admitted to the ICU due to hypotension in the setting of acute pancreatitis. CT scan reveals a focal area of necrosis in the head of the pancreas. Now, if we ended up debriding this, it is possible this guy could end up with a Whipple, but that would be unusual. Which of the following is true regarding the management of severe necrotizing pancreatitis? Well, all fluid collections should be followed and not initially drained. We might have to drain them later, but initially stay out of the belly, don't stick needles in, don't infect it if it's not infected. Another question. When considering the imaging required for our patient, which of the following is correct? Well, a CT scan is the most accurate single imaging test for establishing the diagnosis of a pancreatic phlegmon and acute pancreatitis. Not MRI, not MRCP, not ultrasound. Ultrasound is better than CT for looking for gallstones, but we're looking at the pancreas. Any questions, hit me with an email. If you want to, you can double click on this right here and download the Word file, and it's a list of all the learning objectives if you like them that way. Thanks for listening, and you know where I'm at, know where to get a hold of me if you've got questions. Hope you enjoyed the talk.